Our next speaker is Dr. Steven-Huy. I have the pleasure to introduce Dr. Steven-Huy. He is a professor of medicine and associate director of Asian Liver Center at UCLA. He is gonna discuss very challenging topic this morning, which is autoimmune liver and biliary disorders. Dr. Huy.
Thank you, Mohammed. I'd like to thank the course directors for inviting me to speak today. I'm going to discuss a kind of a complicated topic. I'd like to first acknowledge one of our fellows, Tyra Gu, who actually shared these autoimmune hepatitis slides with me. I think she did a good job of summarizing the recent autoimmune hepatitis practice guidelines. So I'm going to talk about autoimmune-related liver and biliary diseases. So autoimmune hepatitis, here's some basic epidemiologic information. I think we all know it's more common in women. It can be seen in all ethnic groups, all ages. We don't have a lot of good population data to see just how prevalent this condition is, but as you can see, it's not very prevalent, and I'm going to stress that it's not prevalent, and I think, as many of my colleagues know, we see an overabundance of autoimmune hepatitis diagnoses, and as I'll discuss, that's probably because an ANA was ordered and it was positive, but ANA is very common in many conditions, including fatty liver. So how many fatty liver patients have we been diagnosed with autoimmune hepatitis, placed on prednisone, they gain weight, and then they call it autoimmune hepatitis with refractory to steroids, but it was just the wrong diagnosis. So the real autoimmune hepatitis is T-cell mediated. The immune system attacks a patient's own liver, leading to inflammation and fibrosis. And the natural history is really one of fairly aggressive disease. And a patient can have autoimmune hepatitis indolent for many years and then actually even present with an acute liver failure picture. But the bottom line is that most patients with true autoimmune hepatitis, by the time they are diagnosed and present, left untreated can actually have a very accelerated course to end-stage liver disease. So it's important to make the diagnosis, but we have to be careful not to fall into the trap of misdiagnosing. The genetics are here. It's polygenic. So there's really no, if one patient has autoimmune hepatitis, there's no indication to screen family members. There's an association with multiple endocrine disorders, but quite frankly, I never really checked that myself. Two issues, very important. Autoimmune hepatitis, two different types, type 1 and type 2. Type 1 is the classic ANA, SMA, positive autoimmune hepatitis. That's seen in most of the cases, and as you can see, again, the prevalent population is women and young women. So that's the common type 1. Type 2 is the one that we hear about, anti-LKM. I have not seen an anti-LKM positive patient in my entire career. Actually, when I spoke to Dr. Reynolds, our mentor, he had never seen an anti-LKM, so it might be a figment of somebody's imagination. Clinical presentation. So very important to make the diagnosis, but again, autoimmune hepatitis patient can be completely healthy and then all of a sudden come in with very, very acute severe disease. So it's important to make the diagnosis, and I can't tell you how many patients actually come in with liver failure due to autoimmune hepatitis. And I actually think I see more patients with true autoimmune hepatitis who present in acute liver failure than actually come into the clinic with a diagnosis of autoimmune hepatitis based on ANA or something like that. So it can be very rapid. So the diagnosis is very, very important. In this day and age now, and as I'll discuss, our understanding of hepatitis is really changing, but we need to try to make the right diagnosis. So it is still a clinical diagnosis based on history, labs, and specific serologies. Liver biopsy is still important. So up to half can actually have asymptomatic disease, but at some point, an untreated autoimmune hepatitis patient will become symptomatic. So we need to check the liver panel, of course. We always look at that IgG level, which is characteristically high in autoimmune hepatitis. ANA, SMA need to be checked, and they should be checked together. ANA positive alone does not diagnose autoimmune hepatitis. And we still check LKM, even though, as I mentioned, I've never ever seen one, neither had Dr. Reynolds. It's a diagnosis of exclusion. So before we diagnose autoimmune hepatitis and put everyone on prednisone, rule out fatty liver, rule out everything else, rule out all other hereditary type of conditions. So there are some features that would I would say absolutely diagnose autoimmune hepatitis, and they're in the definite column there. So liver histology is very important, biochemistry, the serologies, the autoimmune antibodies, and again, rule out all other causes. And then there's some of the probables. The histology, if you get a liver biopsy, the hallmark is this interface hepatitis. They always say, look for the plasma cells, and if you see sheets and sheets of plasma cells, that's very supportive. But even in the absence of sheets and sheets of plasma cells, the patient can still have autoimmune hepatitis. So liver biopsy is part of the diagnosis. If you can get one, it's ideal. If you see interface hepatitis, that's the hallmark. And then it's important, I can't stress the importance of becoming good friends with your local pathologist, because sitting down with your pathologist and going over the slides with them often brings out a lot of the nuances rather than just what you get on a report. So the serologies are very important. In true bona fide autoimmune hepatitis, the ANA and the SMA will, for the most part, be positive in the vast, vast majority of patients. Again, LKM can be checked, but is very infrequent. But if a patient has ANA positive, again, that does not necessarily make the diagnosis. As I'll show you, there are a lot of other conditions that can cause the autoimmune hepatitis serologies to be positive. We check p-ANCA a lot. That's usually a good marker potentially of PSC and IBD. Anti-SLA is a very specific antibody, so you can order that if you're in a crunch trying to decide. That can maybe help you nail the diagnosis. So it's a difficult diagnosis, it's a clinical diagnosis, and the American Association for the Study of Liver Diseases had tried to simplify things for us and came up with a scoring system. This will help. It takes into account a lot of different things, clinical history, labs, and histology, and if they have a point score of 10 or 12 or greater, that's probable. Point score of greater than 15 is definite, and these are all prior to treatment with prednisone. So here's a slide of all the criteria that go into this score. So they look at gender, they look at labs, they look at autoimmune antibody serologies, history, alcohol, yes, no. And you can see at the bottom there, histology is an important part of the score. You can gain up or down 3 points just based on the histology. So again, I think, before a patient is diagnosed with autoimmune hepatitis and then committed to lifelong immunosuppression, because that's what it means, I think it's worthwhile to get a biopsy to really help nail the diagnosis. At the very bottom, treatment response. Their response to steroids also is very indicative of whether you are dealing with autoimmune hepatitis. So this is the score that we use, and I really encourage you to, if you are trying to diagnose autoimmune hepatitis, to do this score, because it'll help rule out a lot of misdiagnoses. If that table was too big for you, they came up with a simplified, smaller scoring. This is the simplified scoring system, and you can look at these. And again, is fairly specific, fairly sensitive, and you add up the points. So if you do think you have a patient with autoimmune hepatitis, then these are the indicators for treatment. So over to the left column, those are the absolute indications. So obviously a patient with high transaminases, a patient with clear-cut histology showing active disease, or a patient with significant symptoms, we're talking jaundice, evidence of real liver dysfunction. Those are all absolute indications. In the middle are relative indications for starting treatment, and on the right are patients that probably don't have autoimmune hepatitis, and we need to really hunt for the diagnosis a little bit better. And the treatment regimens, the nice thing about autoimmune hepatitis is patients are very responsive to corticosteroid therapy, and these, some authors have recommended starting patients as high as 60 milligrams with a quick taper. I come from the Telfer-Reynolds school of treatment, in that 30 milligrams of prednisone is probably more than enough to control true bona fide autoimmune hepatitis. So we always start low, 30 milligrams with a taper. And we also like to introduce azathioprine at the same time, because obviously you'll want to cover the patient long-term with azathioprine. They can't remain on prednisone. And in patients with true autoimmune hepatitis, what I've found is that frequently they'll require some baseline prednisone. And so it's not uncommon that I have my patients on azathioprine 50 milligrams a day, prednisone 5 milligrams a day, and they should do quite well on that dose. And again, autoimmune hepatitis responds very well to treatment. So if you diagnose autoimmune hepatitis, you start them on 30 of prednisone, and the transaminases don't improve, you probably have the wrong diagnosis. And the most common diagnosis that we're seeing is NASH, misdiagnosed as autoimmune hepatitis. The treatment endpoints, in a nutshell, is indefinite therapy. I think most patients will require the azathioprine lifelong. You often get into discussions with the patients because, again, most of them are young women. They want to know when they can stop treatment. But I think the risk of a flare stopping treatment is high, and for the most part, I keep them on treatment indefinitely. Dr. Reynolds used to teach us the most important things are never to miss diagnoses that are treatable. So you never want to miss autoimmune hepatitis because it's completely treatable. The treatment's very effective, and if you treat them appropriately, these patients can avoid the need for liver transplant. So it's a difficult diagnosis to make. Again, the prevalence of true autoimmune hepatitis is very low, and we misdiagnose a lot. And we misdiagnose because we order ANAs in patients with abnormal transaminases all the time, and they come back positive, and then the diagnosis of autoimmune hepatitis is made. But again, the ANA positivity is seen in a multitude of conditions, including PBC, drug-induced, NASH should be on that list, but it's a very non-specific test, the nuclear antibody. And so we came up with this term overlap, which quite frankly I think is a term that we made up because of our own uncertainty about the true diagnosis of autoimmune hepatitis. But the truth of the matter is nothing in medicine is clear. Medicine is still an art, not a science. And many diseases do overlap. And I heard a great lecture by Keith Lindor not too long ago. And this term overlap, I think, will slowly go away as we learn more about diseases and we learn that there are specific diseases with specific diagnoses, and the example he gave is in the old days we called everything hepatitis. Abnormal transaminases, hepatitis. And in the old days, the only way we could treat was prednisone. But the truth of the matter is we learn more about hepatitis. We learned that there's hepatitis A, hepatitis B, hepatitis C. We learned there's alcoholic hepatitis. We learned that there's autoimmune hepatitis. So as new diagnoses were coming up, the general term of hepatitis, we were coming up with specific diagnoses, each diagnosis requiring a different treatment. So overlap just means that we still haven't found out the specific disease entity that is a mixture of different things. So I'm not going to spend a lot of time talking about PBC and PSC because those are fairly specific cholestatic diseases. But again, there is overlap. There's overlap between autoimmune hepatitis and PBC. There's overlap between autoimmune hepatitis and PSC. And most of it is based on clinical similarities in the way the patients present, plus or minus the autoantibodies. Well, I think the new big thing now is this whole idea of IgG4. And this is what is probably going to now specify that diagnosis that we call overlap. Is it autoimmune cholangiopathy? Is it really PSC? We've now have a new disease entity called IgG4. So IgG is the most abundant immunoglobulin. IgG4 accounts for a small fraction of total IgG. And if you look at the IgG4 concentration, upper limits of normal are variable, but in general, at a lab at UCSF 86, other labs 121. But in general, an IgG4 level of greater than 135 would, for the most part, be indicative of an abnormality. Now, IgG4 being elevated causes a lot of conditions, including fibrosis. The patients, if you biopsy the affected organ, can have IgG4 positive plasma cells. But IgG4 related diseases, there are many of them. And a patient who has IgG4 related diseases can have any one of these organs affected, including the liver, including the biliary tree, the pancreas. So all of these organs can be affected by this abnormality. The two main features of IgG4-related disease are histologic, so you see a dense infiltrate of lymphoplasmacytic cells, and fibrosis. And you see an elevated number of IgG4 positive plasma cells in the biopsy tissue. The pitfalls are overdiagnosis of IgG4-related diseases can be made because elevated IgG4 can be seen in other conditions, including pancreatic adenocarcinoma and cholangiocarcinoma. So before you diagnose someone with IgG4-related disease, you have to rule out other potential diagnoses. So we see elevated IgG4 in PSC, inflammatory bowel disease, and most importantly in the malignancies. So if a patient presents with what looks like some sort of cholangiopathy, and you do check the IgG4 level and it's elevated, that almost means that you're obligated to rule out malignancy first. The IgG4 to IgG ratio is very powerful, and if the ratio is greater than 40%, then that is more indicative that you may be actually dealing with IgG4 related disease. So you have to balance the diagnosis between levels and a liver biopsy, but as you'll see, biopsy, though important and helpful, is not necessary in making this disease. So I'm going to just spend the last few minutes concentrating on IgG4 related autoimmune cholangiopathy, because this is what we previously called overlap, but now I think overlap is IgG4 related autoimmune cholangiopathy. So if the patient clearly does not have primary sclerosing cholangitis, does not clearly have autoimmune hepatitis, but has some mixed biliary autoimmune type of picture, we need to check IgG4. We need to rule out this disease because that's the specific disease that we're now dealing with, which is, clarifying our understanding of what this whole overlap business is. Dr. Keith Lindor, who is an expert in this field, his definition of IgG4-related autoimmune cholangiopathy: bile duct strictures consistent with PSC in patients with elevated IgG4 levels. Again, biopsy is not required. To have IgG4-related autoimmune cholangiopathy does not require involvement of other organs. So the patient does not have to have IgG4 autoimmune pancreatitis, for example. The clinical presentation, again, asymptomatic to very acute disease with deep jaundice. Now here's the big difference. Unlike autoimmune hepatitis, which is predominantly younger women, IgG4-related autoimmune cholangiopathy are typically older men. And again, it can be related, it can be associated with, for example, IgG4 autoimmune pancreatitis, and if other organs are included, it's supportive of the disease, but it's not necessary. So clinically, IgG4-related autoimmune cholangiopathy is similar to PSC, but it's important to make the diagnosis, number one, because patients with IgG4 autoimmune cholangiopathy have more aggressive disease. They're more likely to die. They are more likely to require liver transplant. And they are very responsive to steroids, as opposed to PSC. More often, if you do your cholangiogram, the strictures are more frequently at the bifurcation, unlike PSC where it's more diffuse. But again, if you think about it, cholangiocarcinoma most likely occurs at the bifurcation. So again, if a patient comes in with this clinical picture with elevated IgG4, you have to pay particular attention to ruling out malignancy. So again, this illustrates the importance of distinguishing IgG4-related disease versus true PSC, because the natural history is different. IgG4-related autoimmune cholangiopathy is much more severe with a poorer survival. So again, IgG4 level is the hallmark. A level greater than 135 is fairly sensitive, fairly specific. If it's much higher than 300, it's very, very specific. Other supporting labs are down there below, but again, you can see these things also in PSC. Cholangiograms are important, MRCP or ERCP. And again, you're looking for the characteristic stricturing at the bifurcation, which would be more indicative of IgG4-related disease. A biopsy is not particularly important unless you are concerned about malignancy. So rule out cholangiocarcinoma, If ERCP with brushings and biopsy are important, but if you make the diagnosis of IgG4-related autoimmune cholangiopathy, then steroids are very important. Again, the disease is very responsive to steroids with improvement frequently within 6 to 12 weeks. So this is just a table to compare, but you can see PSC versus IgG4-related autoimmune cholangiopathy. Most of this I've discussed already. And this shows the comparison in how to diagnose, look at the difference in the patient demographics, look at the cholangiogram, rule out cholangiocarcinoma. Again, the association, if other organs are involved, then that is more supportive of IgG4-related disease. And again, steroid therapy is very effective in IgG4-related disease. The treatment is very similar to autoimmune hepatitis. It's again azathioprine, prednisone. The taper is slower with IgG4-related autoimmune cholangiopathy, so they require longer steroid taper, usually on the average of 1.5 to 2 years. And rituximab has not been well studied, but in cases of truly steroid refractory cases, it's probably a potential treatment. And that's it. Thank you very much.